Hi, everyone, and welcome to the Colorado State University Prevention Extension Cast. I'm Nate Riggs. I'm the Executive Director of the CSU Prevention Research Center. And I'm really happy to be joined by three of my very closest colleagues, who you're going to meet in just a second, Dr. Dave MacPhee, Katelyn Dame, and Nicole Mingola. Dr. MacPhee is a professor emeritus, which means he's a retired professor in Human Development and Family Studies, but is also the Prevention Extension Cast's first two-time guest and the director of the PRC's Community University State Agency Division. So in his own words, Dr. MacPhee is a failed retiree, which works out pretty well for the PRC because he has a wealth of knowledge and understanding around best practices for prevention program development, implementation and evaluation, and actually developed those three classes for the CSU HDFS graduate programs, which both Katelyn and Nicole are a part of. They are both star students in the CSU Department of Human Development and Family Studies Masters in Prevention Science program. So Katelyn and Nicole are both graduate research assistants at the PRC and are in the process of finishing up their master's theses. So the topic of Katelyn's thesis was on the role that dance and movement may have on improving maternal mental health and well-being. So pretty interesting topic there. And the topic of Nicole's thesis was on adolescent leadership, self-efficacy, and the association of that with future orientation, which is the extent to which an individual thinks about, anticipates, and plans for the future. So some pretty good research coming out of our prevention science master's students. Now, together, the four of us have a contract with the Colorado Office of Behavioral Health. And this is to develop research to practice tools around implementation fidelity and best practices for program adaptation. So as many of you all know, and I have experience with, is that oftentimes what can happen is that communities will select an evidence-based program, they'll get trained in it, and they'll begin implementing it, and then almost inevitably challenges arise and things happen, and communities wonder if it's okay to alter the program to fit their community-specific strengths or needs. But as we'll see, these adaptations can run the risk of decreasing the positive impact of these evidence-based programs, especially if they aren't made according to best practices. So over the past few months, we've been diving deeply into the implementation literature and developing these research to practice tools to share with the Office of Behavioral Health's SAMHSA-funded substance abuse prevention block grantees. And a little bit later, Katelyn and Nikki will share with you some of the tools that we currently have in development. So we've been really engaged in this topic of today's Prevention Extension Cast. It's entitled, What's All the Tension About? Implementation of Evidence-Based Programs with Fidelity versus Adaptation. So for those of you who are new to the Prevention Extension Cast, I'll be moderating a 45-minute Q&A with Dave, Nicole, and Katelyn. And then after that, we'll have some time for our guests to respond to any questions that emerge from the audience. And we know that this is a topic that, quite frankly, we at the PRC receive a ton of questions about. So don't be bashful and feel free to enter any questions that you might have into the team's live chat, and I'll relay them to our guests near the end of the cast. Before we get to that, I'd like to thank the National Institute of Food and Agriculture for providing funding for the Prevention Extension Cast. This is the third of 12 that will be streaming over a 2-year period on prevention-related topics. And we want to make sure that as many of these topics are driven by our audience. So please, I've asked this almost every time that we've had a Prevention Extension Cast, and nobody takes me up on it. So please take me up on this. Please drop any Prevention Extension Cast ideas in the chat, so that we can really be responsive to your interests. We want to be as responsive as we can to our community and the issues that are popping up in your area related to prevention. So let's get to it. And I will start with Dave as the veteran of the Prevention Extension Cast. The first question that I have for you is really a grounding question around what are evidence-based programs, or what we refer to as EBPs sometimes. What are evidence-based programs, and what is the process by which a program becomes evidence-based?
Thank you, Nate. Am I live? Okay. Good question, long, complex answer. So the details I'm going to provide are based on three things. One, I developed and taught the class that you are now teaching, Prevention Program Evaluation, one segment of which relates to implementation and fidelity. Also, I've worked for a long time in collaboration with Extension folks. One of those collaborations was an article that appeared in Journal of Extension on just this topic of evidence-based programs and implications for Extension folks. I'm also going to draw today from the standards of the Society for Prevention Research, where they lay out in great detail the elements of an evidence-based program. So it's going to be a combination of kind of an academic brain dump and lived experience on my part. So let me quote from the article that I wrote with Bob Fetch, an extension specialist, and he's also semi-retired in human development family studies. So one definition of an evidence-based program, excuse me, is they're a well-defined program that have demonstrated their efficacy through rigorous peer-reviewed evaluations and have been endorsed by government agencies and well-respected research organizations. EBPs are not simply characterized by known effectiveness, they are also well documented so that they are more easily disseminated. So from the perspective of a potential consumer of these programs, this emphasizes to folks on the ground, like extension agents out in the community, their ability to evaluate the quality of evidence for program effects and or skills at finding trustworthy clearinghouses of such information. Those clearinghouses are commonly called registries like blueprints, which I think will be mentioned later on. So there are multiple standards that define what an evidence-based program, and I'm drawing here from the Society for Prevention Research Standards. An evidence-based intervention is one that has been tested in research, meeting the efficacy standards described in these standards, and that has been demonstrated in this research to achieve statistically and practically meaningful improvements in health and wellness or reductions in disease or related problems. So one thing I want to emphasize there is the statistically quantitative basis is one thing for evidence-based programs. Qualitative measures typically do not, although qualitative outcomes can be used for evidence-informed practices. There's a difference between the two there. So an assumption on which these standards are based is that high-quality research on such interventions will lead to beneficial change. So there are two basic elements of an evidence-based program. One is usually at least one, often two or more efficacy trials. Efficacy trials are highly rigorous research-based processes where you have randomized assignment to the intervention in the control group. You have a clear theory of change, which is absolutely essential for doing replications and implementation as a guidepost or a guideline. A lot of well-documented information about implementation, solid, valid outcome measures, statistically significant outcomes, no iatrogenic effects or harmful effects, none at all. So that rules out programs like abstinence-only education to prevent teen pregnancy. The DARE program is a case and study of having harmful effects as well. And then follow-up measures, outcome measures, ideally at least a year later, to see if there are any long-term impacts. So that is an efficacy trial. And then an evidence-based program should also have at least one effectiveness trial. And I'm quoting here from the standards. While it remains important to develop and test new prevention approaches, the field must simultaneously demonstrate that observed outcomes from efficacious interventions generalized to a wider range of populations, settings, and times, and these effective interventions can be translated into regular practice in communities. So an effectiveness trial is about real-world conditions, and that's where you get into this rub between fidelity to implementation and adaptation to local needs. There we're talking about effectiveness kinds of issues. So the Standards of the Society for Prevention Research and registries usually require evidence-based programs to have, in addition to the statistical evidence, well-constructed manuals, appropriate training for those delivering the program, sufficient training such that most EBPs have at least 20 or more hours expected of training in the program's delivery, and technical support available to allow third parties to adapt and implement the intervention. And they should also in the manual have implications discussed about the practical importance of the intervention and the outcomes, not just statistical significance, but practical significance. Is it moving the needle on health or reducing problems? Different registries have different criteria, but usually all of them encompass what I've just talked about as the main features. So evidence-based is more than just a collection of data on client satisfaction. That's a no-no. Not that you shouldn't collect it, but it does not provide evidence for efficacy or effectiveness, or baseline and post-test measures over a short period of time with one group, that kind of thing. Methodological rigor and in-depth documentation of program processes are essential features of evidence-based programs. So that's a rather exhaustive brain dump, but I think it answers your question.
Yeah, thanks, Dave. It does answer my question, and it leads me to a follow-up question that I have for you. You listed a lot of criteria for what an evidence-based program can be. Should we be thinking about evidence-based programs as an either-or dichotomy, or I've also heard people refer to evidence-based as a continuum of competence in that evidence. Can you talk to the audience about that?
Yeah, it's not either or, and one reason for that is because evidence-based programs are based on the accumulation of information about its impact. So there may be an intermediary area that I'll talk about in a second that we call promising programs or evidence-informed programs, that kind of thing. But let me talk about the extremes real quickly and then kind of fill in that middle ground a little bit. So a lot of considerations come into play on that spectrum. Chief among them are cumulative evidence, like I said, multiple efficacy and effectiveness trials, ideally. Variations in the rigor of the design, usually a quasi-experimental design where there isn't true randomized assignment, may provide preliminary evidence for effectiveness, but it doesn't make it an EBP. And then whether any harmful effects were observed. So at one end of the curriculum, would be programs that either have no discernible impact or they have a harmful impact. And I already mentioned two of those, DARE and abstinence-only education. At the other end would be, the top flight, well-documented programs, life skills training, for example, comes to mind as one of them. And then in between would be programs that have been evaluated with pre-post test, quasi-experimental, maybe one rigorous trial, but not an effectiveness trial, those kinds of things. And like I said, these are often labeled as promising practices in various registries. Federal ones in particular would use that label. Maybe there have been one or two quasi-experimental designs. Not all the outcome measures might show significant short-term effects, so they need to do more trials to find out if some other important outcomes are being modified by the intervention. Maybe there hasn't been more than one real-world trial to find out how it's effective out in the community, that kind of thing. So it might be that long-term follow-ups haven't been done to detect whether there's what's called a fade-out effect, where initial evidence is promising, but it evaporates. I've also done evaluations of programs where there's been a sleeper effect, where program effects emerge not immediately, but a year or two later, which would provide evidence for efficacy. Extension can play a role in these intermediary ones in conducting effectiveness trials under real-world conditions, for example. So that might help move the needle from that promising practices up into an evidence-based program with Extension's involvement. And that's been my experience in collaborating with Extension too, is over time we've been able to collect enough data to show that Dare to Be You is an evidence-based program, for example. I think that's it.
All right. So yeah, thanks. You were talking about the distinction between an efficacy trial that's conducted under the really strict control of the researchers and effectiveness trials where the intervention is unleashed into communities and implemented in real world conditions. And in those efficacy trials, it's relatively easier to ensure that the program is being implemented with what we call fidelity. But then once we get into the effectiveness trials and programs are implemented in the real world, fidelity becomes a little bit more challenging to ensure. First off, can you tell us what is fidelity and what are some of the primary components of fidelity? I recognize that there's no single agreed upon definition of what's included within fidelity, but can you tell us a little bit about that?
You probably don't want my answer to be yes, I can tell you that. You probably want a more elaborated answer, so let me delve into that. So basically, fidelity is about whether the program is being delivered according to plan or standard set by the developers of an evidence-based program. That should be outlined in the manual. And the plan needs to be detailed in the program manuals. In evaluating the Family Leadership Training Institute and Dare to Be You, in constructing the manuals, my collaborator in developing the program and I would always highlight these are must-do kinds of things. Thou shalt not cut back on those, ditch them, that sort of thing. Others are more optional. So a program manual should identify what the plan is for delivery, and that would be fidelity to protocol, as it's called. So key components are delivered in a way that hews to the procedures followed in the original efficacy and effectiveness trials, basically. I'll give you a quote here about how intervention fidelity is defined. It's the match between the intervention as it was intended to be delivered and the intervention as it is actually delivered in real world circumstances. So I love to cook, and I want you to think about it this way, what fidelity would be. When I make one of my favorites, oatmeal raisin cookies, I frequently substitute cranberries, dried cranberries, for the raisins. Now, I have not been faithful to the recipe as it is planned, but I still like the outcome. But nobody else would call it an oatmeal raisin cookie. It would be an oatmeal cranberry cookie. So that would be a deviation. It might be somewhat faithful to the idea of a dessert, but it's not faithful to the ingredients. So that's a metaphor for what fidelity to protocol looks like. Is the program manual should outline what the necessary conditions are, the ingredients of the program that must be delivered in order for it to hew to what the program is. Some of the elements of implementation in the SPR standards and other kinds of formats include, first of all, one defining feature of an evidence-based program is the theory of change. Or an impact theory, which is part of a theory of change. So that defines the core components of an intervention. And if one were to replicate a program without adhering to the theory of change, it would not be implementation with fidelity. You really have to respect the processes that are being targeted in the program. This is really critical for making causal inferences about a program, adhering to the theory of change. So if you consider abbreviating an evidence-based program by ditching some critical components, like, let's see what happens if we leave out the sugar in the pumpkin pie recipe, that is not fidelity. And I say that metaphor for food seriously, because I went camping with some very dear friends, and the woman who made the pumpkin pie forgot to put in the sugar. And so we were not eating a pie, we were eating cold pumpkin. Not the same thing, because the key ingredient was left out. This happened in one evaluation that I did of a Dare to Be You, I put in air quotes, replication, were unbeknown to the developer of Dare to BU and unbeknown to me, and without the permission of the developer, this replication director cut the evidence-based program from its usual 30 hours of delivery to 6 hours, and then wondered why the program had no impact. So that is a clear failure to adhere or be faithful to the original program. Limited dosage, no impact. So this painfully illustrates the gap between intention and actualization. Groundwork that needs to be laid out in advance of program delivery would be a part of the implementation process, like building community readiness, collaborations, creating an advisory council, all of those things. They're called community collaborative support systems. They're not at all unusual in evidence-based programs where you need to work with the community before implementation. Sustainable programs are those with a really good fit between the program's focus and the identified needs of the community. So again, more homework there. Requirements for staff training. Dare to BU and Family Leadership Training Institute both usually have 3-day, almost all-day trainings in order to prepare their facilitators to implement the program with fidelity. If you're seeing the training shortchanged, that's not a good sign for fidelity to implementation. Program coverage or reach needs to be considered. So the program manual for an EBP should specify who the intended audience is, and is the replication program following those guidelines? Or maybe it's an overt adaptation where they say, let's see if it works in the real world with a different population. That's a reasonable approach. One thing we learned in Dare to BU is that it works marvelously well for families with kids under 12, total failure for families with adolescents. So who is the program intended for? And then the manual should have a clear statement of for whom and under what conditions the intervention is expected to be effective. So like I said, the Dare to BU program is limited in one sense for who it serves, and we can think of any number of other examples too. So it's a long-winded explanation of fidelity protocol. It's truly a complex, vexatious kind of issue because most community programs do want to adapt in some way. So the trick becomes what's permissible, what should not be done. And that's where I think Nikki and Katelyn will talk about, the green light, yellow light, red light kind of indicators of when not to adapt the program.
Great, thanks. So you talked about the importance of implementation fidelity, but can fidelity, and I guess especially strict fidelity to manuals, be challenging for some communities? And if so, why might that be?
A short answer is absolutely. I wouldn't say an issue, but it can be a head scratcher. It can be a difficulty, that sort of thing. There may be local needs that are at odds or at variance with the needs in the communities where the program was developed. That's why we do effectiveness trials to see how well it works with a diverse audience, a range of them. It might be that there are shortages of resources to deliver the program that might ideally up front require some conversation with the program developer around how can we tailor this using fewer resources. That's very common, a very common reason for failure to adhere to the program, failure to have fidelity to it. It might be especially cultural issues. I've encountered that in almost every program I've evaluated where we were working with a different cultural group. We were not entirely sure up front how much that would affect the program. Talk to the developer of the program about how can we make this more culturally relevant without altering or running afoul of the underlying theory of change. The most common reason for deviations from protocol, though, is running out of time. that's empirically supported. Something like 85% of the modifications or deviations from protocol are running out of time. So one recommendation is have a backup plan, ideally guided by the manual, like assigning homework to cover the material, or abbreviating a curriculum module in a way that still gets at the processes and the theory of change. And then recently became aware of an article by our colleague in the PRC, Brian Bumbarger, and some colleagues at Penn State. Proactive adaptations are much better than reactive ones. You at least have the time to get in touch with the program developers to say, would you support us making this adaptation? Reactive ones are much more likely to fail to have the desired impact than proactive ones. And I probably missed a few there, but yes, common for replications to want to do some kind of adaptation or fiddle with the curriculum.
Great. Thanks for that, Dave. And at this point, I'd like to introduce our common colleague, Katelyn, Dame. Dave gave a pretty good prelude into adaptations, but Katelyn, can you tell the audience what exactly it would be considered a program adaptation?
Yeah, thanks, Dave, for all the wonderful information. Dave did touch on this a little bit, but essentially an adaptation is really any change to an evidence-based program. So this could be any addition, subtraction, or simple and complex modifications to any of the prescribed program material or components, or even the logic model. And some examples of adaptations could include just changing the location or the time of the program to better suit the participants' needs. Maybe you alter the length of the sessions or the lessons prescribed by the program model. And then, as Dave kind of mentioned, you might change the primary audience that the evidence-based program was targeted to. And some even change the names to the program lessons or activities so that they're more culturally appropriate. But importantly, research has shown that adaptations tend to be common practice, and this is actually what we hear a lot when working with our community partners. They are common versus rare occurrences, because when you are implementing evidence-based programs in the real world or natural settings, it's really often impossible to implement with 100% fidelity. So overall, there tend to be those who are really in favor or neutral about adaptations to evidence-based programs, while others believe that adapting these research-based programs really represents poor implementation and program outcomes. So those who tend to be in favor, believe that this could increase individual and local buy-in. And furthermore, they believe that these adaptations are really necessary just to meet diverse population-specific needs. And they often state that evidence-based programs really are not tested among diverse samples, so it is hard to determine what they need. But on the other hand, you have those who discourage these adaptations because they believe that strict fidelity must be adhered to in order to achieve the desired program outcomes, because that's what the research shows. But regardless, this fidelity versus adaptation debate is really currently based on predicted conclusions and not always empirically based evidence. So really the research kind of needs to shift to areas of fidelity and adaptation when evidence-based programs are implemented in real-world settings, so that we can understand better about what evidence-based programs need and what adaptations are occurring.
Wonderful, thank you, Katelyn. What are some of the reasons, when you did your deep dive into the literature review, what are some of the main reasons why communities end up wanting to or feeling like they need to adapt evidence-based programs?
Yeah, so as Dave mentioned, one of the most common reasons for making these adaptations is a lack of time. And this reason has been especially true for school-based settings, and especially with the ongoing COVID-19 pandemic that's caused a lot of closures and just shutdowns of schools and community activities. So this has really required that many evidence-based programs be adapted by decreasing or omitting lessons taught. But additional reasons can include Maybe the organization has other competing resource or time demands and they can't completely commit to the evidence-based program in the way it needs to be. Or the implementers have limited resources, skills, or knowledge that's needed to implement the evidence-based program. Maybe the organization has difficulty recruiting or retaining the participants. They might find that there's a lack of fit with the program and the community culture needs. And so they attempt to respond to individual needs with adaptations, or sometimes even health statistics or information just needs to be updated with current health recommendations and standards. And these really are common reasons that we consistently hear when we're working with these community partners. And additionally, program adaptations may sometimes occur if the goals don't really align with the organization's overall goals, but these adaptations aren't necessarily recommended. It may be best to just look at switching programs or something like that. But ideally, and Nikki will get more into this, but when you make adaptations, implementers should really attempt to think of these reasons why a program may need to be adapted prior to implementing with the community and really speak with their stakeholders about what they're attempting to do.
Excellent, thank you. So you mentioned that sometimes the data or the statistics need to be updated. And I think this gets at a broader issue of, sometimes these evidence-based programs, the evidence upon which those programs are designated to be evidence-based is old. And the program may feel a little bit dated or need a refresher or something like that. And the friend of the PRC, Miranda, asked the question that you might see in the Q&A. How do you maintain fidelity with a program that has become a little bit dated and could use a little bit of a refresher? And I'll open that up to any of the three of our presenters if they have any ideas how to do that.
Could you repeat that question real quick, just to?
Yeah, sure. So I think something that can happen is that a program, prevention science has been around for a few decades, right? And there have been programs that have been evidence-based in the last couple of years, and then there are programs that the evidence was established maybe a couple of decades ago, and the curriculum may be a little bit older and in need of a refresh, or maybe is a little bit stale. Are there any kind of adaptations that communities can make that would be maybe what we'll talk about as green light adaptations for programs that might feel a little bit dated? And maybe I'll pass that one to Katelyn.
Yeah, and really, I think especially if you're doing these adaptations, which a lot of people laugh at us when we say, talk to the program developers and see what they recommend, because they can often be difficult to get in touch with. So I think kind of your next best option is to really dig into the empirical research and find out what's actually there, making sure that you're using reliable resources to gain the best and most accurate information that you can. And if there are professionals in the community that specifically work maybe with the participants who assess their diverse needs and meet those needs, then they might have great recommendations as well for adapting the program.
Okay.
Does that kind of answer?
Yeah, it does. And I think that Dave also has something he wanted to say about that.
I think a foundational response to your question, Nate, would be the literature generally leans toward being faithful to the theory of change or the impact model and being more of a green light about adapting materials and that kind of thing. So updating any visuals to be more inclusive of diverse people would be an appropriate one, as opposed to altering whatever curriculum units there are that are targeted at the theory of change. So it's kind of details versus the big picture that I think we're talking about here.
Great, thanks, Dave, and thanks, Katelyn. All right, so now we're going to move on to some questions for Nicole. So Katelyn and Dave both talked about some risks to making adaptations. Is it ever okay for communities to adapt EBPs or evidence-based programs? And if so, under what circumstances, and are there best practices for program adaptation?
Yeah, I guess I get to be more of the good guy here and say, yes, communities can adapt. But, you know, there are best practices, yes, and you do have to be careful with this. So I guess what I'll say is, although the most effective adaptations can be tricky, they will be time consuming, they can also sometimes help connect the program to your unique community. So thinking of fidelity as strict adherence is kind of going to be a barrier, but when you think of fidelity as a broader spectrum and include participant responsiveness and connecting with the community in that way, I think that can kind of broaden our understanding of fidelity and adaptation. So I guess you talked about like the circumstances. So what comes to mind is this article that we've brought up a couple times, and it's by Moore, Bumbarker, and Cooper, and we can probably share that as well. But during the study in 2013, they basically found that adaptations can potentially increase program effectiveness. And this basically gets to when the adaptations are implemented with care and caution. And that's basically what I'll stress on this section here is, you know, not adapting just because you want to or you think that it's going to benefit your community, but really taking time to think about, why am I adapting? Is it aligning with the program's theory of change? So in this study that I'm referring to, about a third of the EBP adaptations in the study had a positive balance. So positive balance meaning that the adaptations did align with the program's theory of change. And this is really our goal. This is what we're aiming for with adaptations. And in that study as well, the last thing I'll say is that the proactive adaptations, or those that were thought about and made before the implementation, were those that were most likely to yield positive balance or aligning with program theory. So that's an example. So circumstances, ideally you'd be doing these adaptations proactively before implementation. And really, I would suggest taking that piece of fidelity, which is participant responsiveness, and really focusing on that as one big aspect of fidelity. Are your participants going to be engaged? Are they going to be receptive of the program? So thinking of this in the terms of like an implementer implementing the program with 100% adherence, but if the participants are not understanding it, maybe culturally, linguistically, or developmentally, if there's a barrier there, then maybe we do need to adapt and make sure that the participants are engaging and able to receive it. And then some things that we found in the research for circumstances of adaptations, a lot of what has come up already. So outdated material is a huge one. So updating pretty much statistics, I would say, is a huge one. The need for developmentally or culturally appropriate material, and responding to individual needs. Those are the biggest circumstances that we found in the research. And with all of this, though, it still needs to be considered beforehand and be and with care and caution, essentially. And I guess to answer that best practices portion of this question, I'd say it's really not a cookie cutter approach, but the goal is really finding that balance between fidelity, all parts of fidelity, and adaptation, and being realistic with it. We know that this is life and we have to roll with the punches sometimes, but as long as we are taking that care, that's essential. So at the PRC, we are working on developing some research to practice materials in this space, actually. So what we turn to and suggest for people to use is this red light, green light model of adaptation. it is, we found this through ETR Associates and CDC, Division of Reproductive Health, and we've kind of adapted it a little bit at the PRC. But the idea behind this red light, green light model, which I think we'll have time to go over in a little bit, it's just the idea that you're not adapting just because it's your opinion or you think it's a good idea or you assume participants won't like the module, but instead really making efforts to withhold fidelity at all aspects and focusing on what participant responsiveness means in your community. So I think that answered all of your questions within your question.
Yeah, I realized that was 3 questions in a single question. So that's some excellent working memory on your part there, Nicole. Nice work. And the other question that I have here, I'm looking at our time. We have about 20 minutes left. And I'd like to be able to answer questions that come up in the Q&A. So everybody in the audience, feel free to drop those in the Q&A. What I'd like to do now is move towards those research to practice tools and let Nikki and Katelyn, I guess Katelyn will go first, describing one of the research to practice tools that we have around adapting evidence-based programs. So I'll throw that to Katelyn right now.
Perfect. Thank you, Nate. Just let me get my window. Okay. Is everyone able to see that? Hopefully. Okay. So this is essentially our red light, green light tool that we created to help communities to adapt programs if that's something that they're looking at doing. This is just a short little blurb going over pretty much everything that we just talked about, how the adaptations may threaten program effectiveness, but if they're implemented with care and caution, they could actually enhance the outcomes. Here's a handy little, how-to list before proceeding. And as you'll see here, considering your team's time is one of those important decisions to consider. And then also we talk about the need to evaluate any adaptations to determine their effectiveness. And even then, that's kind of up in the air. And then before you proceed, just kind of considering where does your adaptation fall within this red light, green light model. And importantly, red light changes are changes you should not make, as these will impact the program. And this could include deleting lessons or activities and things such as that, and they typically have a negative impact on the outcome. Whereas yellow light changes, we don't really reasonably know what's going to happen, either negatively or positively. And so it's best to contact the program developer, ideally, or your TA professional if you decide to change the delivery setting or substitute any activities. And then finally, we have these green light changes here, which are just minor changes, and they are likely to probably impact the program more positively or not drastically impact it at all. So these are fairly safe changes to make, but again, you should contact your program developer or TA professional prior to doing it. And then just a handy little guide to help you with making the decisions. As you'll see, meeting again and again with your program developer and your stakeholders is a very key aspect of any adaptations that you may make. And this tool will be on the PRC website, I believe, by the end of the month. So now to Nikki, or Nate, either one.
Go ahead.
Yeah, I'll go ahead and share mine. So I have another research to practice tool here. And I'll start in the middle of it here with the 5 components of fidelity. And this is what we were talking about earlier of fidelity is not only adherence, but it's all of these things. It's the exposure and dosage, the quality of the delivery, participant responsiveness is what I was really pressing earlier, and program differentiation. So really, when we talk about the balance, we want to talk about balancing adaptations with all of these aspects of fidelity. And, we talked about a lot of this tool already, so I'll kind of scroll through these couple ones here. A lot of times people ask, how do I measure fidelity? And really, the best way to measure fidelity is if your evidence-based program provides a fidelity checklist or fidelity monitoring tool, ideally you will be using the one provided by that program. If they do not provide one, you're in luck because the PRC is working on creating this general fidelity checklist that would ideally be able to be used across many different programs if there's not one already provided by your developer. And then this is just, we took a few of the top implemented programs in our state and kind of gave these resources of what the checklist will look like, the logic model of the program to kind of guide what is the program's theory of change and are my adaptations aligning with this theory. So that's a good way to balance the two, is looking at the fidelity checklist and also looking at the logic model to see how those are aligning essentially. And fidelity versus adaptation, finding that balance. This is what we're talking about a lot today, of course, but really it is important. This is really our goal, is finding that balance. So the idea here being that we don't want to waste your valuable time by making haphazard adaptations. We really want to put our efforts to work and see these positive outcomes by doing the best we can here. So this is a couple of suggestions of how to find that balance, right? And really step one is really important. So during the program selection phase, we want to really avoid program community mismatch. So finding an EBP that's the best fit for your community is definitely step one. Sometimes communities just don't really have a choice to change, and we have to work with what they have. So at that point, you really want to work as a team, as the implementation team, to understand why are we looking at adaptations and what are the best practices regarding that. And with this, we really need to monitor and evaluate both fidelity and adaptations all the way through. And I know we're running low on time, but I can go through this little, this is like a flow chart that we've created of how to find that balance. So basically, if you start at the top here, the first half is about monitoring fidelity. Oh, geez. Sorry, my computer is kind of freaking out. Okay. Sorry, something popped up on my computer and it all went white. So if you start at the top of this tool, it's basically, are you monitoring fidelity? Yes or no? And you can follow through this flow chart here. And basically the idea is you want to monitor fidelity, ideally by your program's specific monitoring tool. And the second option would be using the PRC created tool, which is not up yet, but it will be to come. And then if you do those things, then yes, you are following the best practices for monitoring fidelity. And the second step here is more about that adaptation piece. So the first question asking, are you considering adaptations? If you're not, that's fine. That essentially means that your program is a great fit for your community. But if you are considering adaptations, go through all of these steps here. Basically, you want to make sure you're contacting your program director, your TA professional, whoever you may be able to contact. You want to also evaluate those approved adaptations once they are approved. And once you are approved, you are evaluating, then you can reach the end of this here. And yes, you have done the work and your team is doing all you can do to balance fidelity with adaptations. And I will stop my share. Sorry for going over time there.
No, that's really helpful, Nikki. And just to reiterate, we're in the process of finishing these research to practice tools up. We have several other ones. Some are going to be specific to cultural adaptations. One of them is going to be specific to how we evaluate, or how communities can evaluate adaptations that they make. We had a question in the chat from Janet. So I'll throw this question to Dave as our program evaluation specialist in the group. What are some ways that communities, best recommendations or best practices for evaluating the adaptations that you make? And can communities partner with the Prevention Research Center to conduct those evaluations?
Well, the easy answer to the second question is definitely yes. We provide a broad range of technical assistance from implementation to well-structured evaluations. Answer to the first question would be you would still want to measure the main outcomes as in the original program. The program developers probably identified, well, they would have had to identify the outcome measures that they were using based on their logic or impact model. If your adaptation is including like an additional unit you want to add to the program to address a particularly pressing issue in the community, family, something like that, then what you'd want to do is figure out, ideally collaborating with an evaluator, how to measure that so that it provides additional evidence for effectiveness. One thing I always try to do as an evaluator also, especially with replication programs, is to collect data that relates implementation to outcomes. So was dosage or the demographic profile somehow related to the outcomes? That provides rich information for how the adaptation might be working. If you're developing culturally appropriate materials for the group, then look to see if it's had a particularly big influence on that particular group. That's about all I can come up with right off the top of my head, but yes, it should alter your evaluation plan at least a little bit. New outcomes or outcomes that are specific to particular groups come to mind.
Great, thanks, Dave. Okay, we have a very applied question in the chat, and I'm gonna throw this one to Katelyn. A program is designed to deliver 24 hours of family-based intervention over 12 weeks. A facilitator doesn't really want to commute 2 hours to the intervention community, so decides to deliver the program in one 3-day session. She justifies this by saying that she's delivering the same program and the same dosage. Would this be a yellow or a red light adaptation?
Ooh, that's a tricky one. I would lean more towards red light just because likely you're trying to keep the dosage. However, this probably won't happen. You're more likely to delete lessons or just omit certain activities. And additionally, the program is probably structured in a certain way to lay out the sessions so that participants have some time to take and consider the lessons that were taught and really kind of ingrain these in the lessons in themselves before returning to learn more skills. So I could see that that could drastically impact program outcomes in a negative way. A more yellow light change to that could be potentially changing the format to be online versus in person. But again, this could negatively or positively impact the program outcome. It really just depends how much of the program's core values rely on being in person and developing collaboration and certain things like that. And then maybe another yellow light change would be, and potentially green light change would be enlisting another implementer that potentially lives closer and could maybe teach one of the sessions for you instead of just trying to push them all together in one 3-day session.
A+ answer, Katelyn. So many evidence-based programs require practice, between sessions and consolidation. So in this particular case, that site had no impact because there was no opportunity for practice. The participants were just overwhelmed with information and it went in one ear and out the other. So I would agree with you that as delivered, it would be a red light change, even though it was planned ahead.
Well, thank you all very much. We don't have any more questions in the chat, but what I would like to say is I have dropped into the chat link to the Prevention Research Center's Prevention Extension Cast website. You can find this conversation probably within the next 2 days, but you can also find all of the previous Prevention Extension Casts on that website, and we hope you're taking advantage of that. There's a lot of great content. Thank you all for joining us today, and we'll see you at the next Prevention Research Center Prevention Extension Cast. Take care, everybody.